Wait a little bit longer for participants to join. All right, so I think we're going to get started. Welcome everyone, and welcome to day 4 of Adam Talks Mental Illness Awareness Week. We're so excited to have Dr. Lorne Sexton with us today, talking about anxiety and older adults. Just so everyone knows, you are not on video and you're not heard, so that's automatically turned off in the webinar format. So no need to worry about that. My name is Vienna Code, and I'm the Public Education Coordinator at Adam, and I'll be your host today and for tomorrow as well. I'd like to thank my colleagues Susanna and Carlene, who've helped make this week possible. And I'd also like to thank our speakers for their willingness to present and contribute to this Mental Illness Awareness Week. Before I hand things over to Dr. Lorne Sexton, I do want to briefly go over Adam and what we offer here. So the Anxiety Disorders Association of Manitoba is a nonprofit registered charity, and we offer virtual self-help programs for all Manitobans who are affected by anxiety. All our staff and volunteers here at Adam have lived experience with anxiety, and we offer programs to adults 18 and older. They're all based on cognitive behavioral therapy, and we provide ongoing support groups for the prevention, education, and management of anxiety disorders to adults. A few housekeeping things I'll go over before we get started on the presentation. This presentation is being recorded, just so everyone knows. However, no one is visible and we can't hear you, so not to worry. We will take questions at the very end. So we'll have about a 10-minute period at the end for Dr. Sexton to answer any questions you may have. You can write those in the question and answer box throughout the presentation. Before starting the presentation, I would like to make a land acknowledgement. So we would like to acknowledge that we are gathered here on Treaty 1 territory, which is the ancestral lands of the Anishinaabe, the Dene, the Cree, the Oji-Cree, and the Dakota people, and the homeland of the Métis Nation. We remember that all the people of all the generations for thousands of years who lived, loved, worked, died, and were buried on this land remain here. They have not left, they have merely been transformed. We remember to tread softly on this earth as we offer our respect and gratitude to the traditional caretakers of this land, those living now and those who have lived before and those who have yet to come into being. I would now like to introduce our speaker of the day, Dr. Lorne Sexton. Dr. Lorne Sexton is an associate professor and associate head of the Department of Clinical Health Psychology with the University of Manitoba. He also practices psychology with older adults and is the director for neuropsychology within Clinical Health Psychology of Shared Health Manitoba, with his office located at St. Boniface Hospital. He has also been actively involved in professional affairs and has served on the board of directors for the Canadian Psychological Association and for the Psychological Association of Manitoba. He was awarded the Member of the Year award by the Canadian Psychological Association in 2013 for his contributions to the profession. Welcome, Dr. Sexton. Thank you for being here, and I'll pass it over to you.
Have to remember to unmute as usual. Thank you. Thank you for attending, even though I will have to give this lecture without seeing the audience, but I've gotten used to some of this during COVID-19 and all the lectures we do here in the medical school and elsewhere without seeing our audience. So my other qualification for this lecture, as you can probably tell by looking at my gray beard, is I have lived experience as an older adult. So I'm also in my 70s and experiencing what I treat. So Pardon me. And I'm talking to you today from my office at St. Boniface Hospital in the McEwen building. And having trouble with making my slides work. So I want to dedicate this talk today to Dr. John Walker, who was director of the anxiety program at St. Boniface Hospital for 35 years. And John loved Adam and was instrumental in developing Adam as it stands today. And because he really believed that access to treatment was one of the major priorities in mental health, and that worked really hard to find ways to increase access to services. John Walker and I started graduate school together and were classmates 50 years ago today, sort of in 1972. We worked together for 35 years at St. Boniface Hospital, and we were good friends at the time of his death in 2018. So because of John, Adam is special to many of us psychologists at St. Boniface Hospital. So let's start with an overview of what we'll be talking about. And so in real quick summary, anxiety in older adults is pretty much exactly the same as anxiety in younger adults. It has the same symptoms and can be treated in the same way. So among psychotherapy, CBT is research-wise the most efficacious, and pharmacologically, SSRIs and SNRIs are the medications of choice from that approach. So of course, one could actually just sort of stop the lecture here, but since you've signed up for the next hour, we'll keep going, and we will drill deeper, because there's actually a lot of interesting stuff to learn about older adults as we explore this topic. And to summarize that in a way, older adults, we will find out, appear on average to have a much lower incidence of almost all mental disorders, including anxiety, than younger adults. And older adults appear to, on average at least, to regulate emotions much better than younger adults. So I ask, does that surprise you? We'll come back to that. So let's do a quick one slide on the basics. Anxiety is our early warning detection system and is necessary for survival every moment of the day. You can't cross the street safely without it. It has two basic components: a autonomic nervous system arousal, respiratory, cardiac, muscular, that gives us strength when we perceive a danger. And it's a cognitive component, which is the perception of threat. Oh my God, there's a man with a knife entering my house. So your heart rate should go up. So we have to differentiate between everyday normal anxiety, which we need for survival, from what constitutes an anxiety disorder. And an anxiety disorder, simply put, is when anxiety becomes excessive, persistent, and often characterized by avoidance. And later in the lecture, when we get to think about health anxiety in older adults, we'll come back to this distinction because it's important. Anxiety disorders start young, even before children enter school. And so the average onset age of anxiety disorders are put up on the screen in front of you. Phobias, the average phobia begins around age 7 and younger, of course. Social anxiety, that fear of being embarrassed in public, starts to kick in a lot in early adolescence, when at that age we're becoming very socially self-conscious. Panic disorders have an average onset age in early adulthood, around age 24. And generalized anxiety, that anxiety disorder characterized by worry, actually has an average onset age closer into middle age, around age 31. And that makes a lot of sense if you think about that worry coincides with the time in our life when we are raising children, working, trying to establish our careers, that we're taking on a lot more responsibility in life. Late life onset of most mental disorders is uncommon and in some cases even rare, with the exception of worry, generalized anxiety disorder, in which 25% does show up in older adulthood. But once anxiety lands, it tends to linger. And so many patients suffer from their disorder for years or decades, as some of you are unfortunately aware. Is there some good news to offer again in old age? The research seems to say yes. And so this is to quote a research review article from 2015, and I quote, "Anxiety disorders reach a peak in middle age, then tend to decrease again with older age. In the 50 to 64-year age group, prevalence rates start to decline, and they were lowest in the elderly, from 65 to 80 and beyond." And these authors said, quite optimistically, maybe a bit overstated, that means that even without treatment, anxiety disorders do not last until old age in most cases. Not in most cases, but in enough to keep me employed. But it does lead, at least from a medical point of view, for a consideration of when somebody who at age 80 is experiencing a severe anxiety for the first time in their life. And so in another psychiatry journal article, it states, because 99% of anxiety disorders start prior to the age of 65 years, late onset anxiety should prompt a careful search for cognitive and other medical etiologies. Cardiac, Parkinson's, COPD, thyroid, many other things might need to be considered. But that isn't to say that older adults don't experience anxiety. Growing old carries with it a lot of stress and a lot of anxiety, and it's a common expression that growing old is not for the weak. So what are those stresses of growing old? Well, happy retirement is a good idea and is mostly the right idea for most people, but many people can experience significant adjustment because of the loss of a sense of identity that they have in work, and certainly a loss of that work structure that gets you up in the morning, out and about, active, and all the social contacts that work bring. I remember a cement truck driver who after he retired, missed the contact with the work crews that he delivered to. Health, we will talk about a lot, is a bigger stress as we age. The average 75-year-old has a minimum of 2 medical disabilities, arthritis, etc. And in our 70s or before, quite common for people to express some anxiety about future disability, about becoming dependent on their children, losing their driver's license, and those kinds of concerns. Dementia is the big concern. And research shows that dementia is the most feared of all diseases in older adults. Younger adults fear cancer, older adults fear Alzheimer's, and sometimes experience a lot of anxiety just because they couldn't remember somebody's name and monitor themselves for small memory changes. Caregiving could be a whole lecture unto itself. As one of the big stresses of growing old is the need at some point in life for one spouse to take care of the other spouse who has an illness or dementia. So that's a potential huge stress that carries with it lots of both anticipatory anxiety and real stress when it happens. And then, unfortunately, there's that Grim Reaper topic, death, self and others. But actually, many times more for others than yourself. A lot of anxiety as we age about which one of us is going to die first, becoming a widow, and then going through the grief of death. And grief can look a lot like depression, but it can also look a lot like a panic disorder, including with heart palpitations for some. So sometimes grief gets mistaken for panic. Not just our close loved ones, but as we age, we will almost inevitably experience the death of our friends, our siblings, our a diminishment of our whole social network. And so an anxiety for social isolation, unfortunately, is a part of growing old. And then bad stuff can happen, like car accidents and home invasions and hospitalizations. And so there's room for PTSD as we grow older as well. But this kind of sets up what's called the aging paradox, that we're not growing stronger as we grow older, we're physically weaker. And there's a lot of difficulties and hardships and stresses about growing old. And yet almost every emotional disorder, every mental disorder occurs much less often as we age, not just a little bit. I've thrown up a couple of graphs. One recent research on panic attacks, the other one a major study in Canada of depression. And what these graphs are saying is that as we go from young to old, from 20 to 80, the rate of panic attacks and depression don't just decline a little bit, they decline amazingly. The pink and blue are forgive me, boys and girls. So the pink line is the rate of depression declining for women, the blue declining for men, and you see they actually start to converge in late life around 80. So it's about the same rate, but declining both at the same rate. And so the point I'm trying to make is that amazingly, in spite of all the hardships of growing old, older adults clearly seem to be less distressed. And that this process doesn't just occur because somehow at age 75, all our stress disappears and we enter the golden years. It's actually happening year by year, decade by decade, across the whole lifespan as we age from 15 to 85. A gradual year by year process. And so it would appear to be a learning process, that we gradually learn to control our stress and emotions better as we age. I think that's what it indicates, and it seems a nice optimistic conclusion. And there's a lot of research that does indeed support the idea that older adults control their emotions better than younger adults. Against whatever stereotypes you have about old age, and we all carry some ageisms with us, older adults on average worry less, experience and express less anger in marital relationships, less drag them out fights when you're 80 than when you were 35. Better life satisfaction, better marital satisfaction, as well as less mental disorders. So that picture of the woman in her garden smiling is somewhat accurate. If you're not convinced by what I've just said, then I would invite you to spend, after we finish today, taking another 11 minutes and listening to a TED Talk by Professor Laura Carstensen, who is the director of the Center for Longevity at Stanford University. Laura Carstensen is a world-famous psychologist on the topic of aging, and her talk entitled "Older People Are Happier" is a wonderful TED Talk available on YouTube. And so just Google "Older People Are Happier." You'll find that picture. It'll be the best 11 minutes that you could possibly spend in your life preparing yourself for your own aging. It will change your attitude about aging make you want to actually get there faster, maybe. So why are older adults so wise and good at regulating their emotions? Well, I would say obviously experience is the source of wisdom. We've seen it all before. And while certain things slow down, including that we don't add numbers together as fast, knowledge actually increases as we age, right into our 80s. And more interestingly, the complexity of our thinking increases. Older adults are better at seeing multiple sides of an issue than younger adults are. We become more conscientious and reliable as we age. We control our anger better as we age. Some of this seems to be motivational, that older adults seem to selectively attend to more positive information and less to negative information, whereas younger adults tend to focus in more quickly on negative information rather than positive information. And older adults simply emphasize positive relationships and the maintenance of positive relationships more strongly. So let's go back and look at some of each of the different mental disorders. And we'll start with generalized anxiety disorder. And we'll start there because generalized anxiety disorder is the disorder that is most likely to develop even in late life, and it is the most frequent late life anxiety disorder that presents itself to clinics like mine. So good old DSM-5 from the American Psychiatric Association defines generalized anxiety disorder really simply. It's characterized by excessive anxiety and worry about a number of events or activities. So the main thing is worry. It's a little more cognitive, not quite as much physiological arousal, but enough physiological arousal that people with GAD tend to be restless or keyed up. And the combination of the two, being restless and worrying, means that when you wake up in the night to go to the bathroom, you can't get back to sleep for worrying and being restless. So insomnia is often the big complaint of older adults with generalized anxiety disorder. Another colleague of mine, but out at Fort Garry campus of University of Manitoba, Corey McKenzie, specializes in research with older adults and has looked at generalized anxiety disorder. And so looking at some of his work, we find that indeed generalized anxiety disorder is common in old age, but once again, it actually decreases over time, even in old age. So from 3.7% of a population in age 55 down to under 2% at age 75, that it's about 50% less generalized anxiety in what we call the old than the young old. So even in old age, we're getting better at regulating these disturbances. And a lot of the symptoms of generalized anxiety disorder are also lower in older adults, even in those who meet the criteria for being diagnosed with GAD. With the one exception, again, of sleep, that sleep might be more disturbed. Sleep is simply already a vulnerable thing as we age. Sleep becomes a little shallower, a little more fragmented as we age. The average older adult wakes up a couple of times to go to the bathroom. And so if there's a tendency to worry and then specifically actually then start worrying about getting back to sleep, then sleep becomes often the main symptom of GAD in older adults. The content of worries changes as we age. We worry as we age, and these are what my anxiety patients will talk to me about. The health issues of both their self, their spouse, family members. Actually, often as much for their spouse as themselves, because they don't want to be the widow. And they worry about the well-being of their children. Once you have a child, it's a lifelong affliction. You're going to worry about them forever, and then you get grandchildren, and you can worry about their well-being too. Dr. Corey McKenzie, one of his main concerns is the fact that many people do not seek treatment. Again, that goes almost back to the existence, and the reason for Adam's existence is how to make seeking treatment more easier for people. And because unfortunately, only about a quarter of people with generalized anxiety disorder, older adults, seek any kind of treatment. So generalized anxiety disorder focuses more on health. So that leads to a nice question of, well, what do people, not just people with generalized anxiety disorder, but all older adults living in the community, living normal lives, what do people worry about? What do people fear? And the easiest way to do that research that's been done is simply to ask them open-endedly, not in a questionnaire where you check things off, but just an open-ended question. You can think about it right now as you're sitting there. What are the specific situations or objects that you fear, that you worry about? And so in order of frequency, we have a list of what older adults say they are afraid of. And the number one biggie is mental decline, dementia. Older adults worry about losing their memory. Number two is illness. Number three is poor well-being of loved ones. There's inability to care for yourself. Diminished health. Well, so you're getting the picture. The top five are all actually health issues. And then as we go down the list, yeah, there's the old phobias snuck in there of snakes and dogs and the darkness, which young children are afraid of. But we fear losing our hearing, we fear losing our sight, we fear incontinence, and we fear falling, all health issues. And falling is actually an interesting one, a specific phobia that can develop in the elderly. And it's of particular note because a fear of falling can get in the way of leading a normal life and being active. So it's one that is of increasing concern to health professionals. And we'll talk about that a little more. So in working with older adults and trying to figure out their anxieties, their worries about health, I find it useful to go back to good old Sigmund Freud. Sigmund Freud said a lot of silly things, and we don't pay too much attention to him today, but he did say some useful stuff. And one of his very useful things was a quite straightforward distinction between three types of anxiety. And I think we should always keep these three different types in mind. First and foremost, there's real anxiety that, as we started today saying, anxiety is our early warning detection system that is necessary for everyday life to keep us safe. And so real anxiety is about valid concerns. Sigmund Freud, because it was the term of the day, neurotic anxiety, we don't use the term neurotic much anymore, but what he meant by neurotic anxiety was excessive anxiety, which you'll recall is what we mean by referring to something as an anxiety disorder, that it's when anxiety becomes excessive. So there's valid anxiety, real anxiety, there's excessive anxiety, and then there's moral anxiety. Anxiety about doing the right thing, about what should we do and feeling often guilty no matter what we do, because it doesn't quite, because there's too many different conflicting choices. And health can be a real anxiety for the elderly, but also at the same time a phobia and full of moral choices. And I think it's very easy to illustrate that quickly by all of our experience over the last 2.5 years with COVID-19. All of us have experienced real anxiety. 2 years ago, especially, people were getting sick and dying, and we were being told to stay home. So real anxiety, real concerns. And then all of us have tried to struggle with, well, what's excessive? When are maybe we're being too anxious? What, are we being too afraid? And not being sure where to draw the line between real and excessive anxiety is. And that's actually changed on us as the pandemic has moved along. What seems normal behavior, normal concerns at one point becomes excessive at another point, because we've had to, as the vaccine has come out, as the Omicron variant seems to have lower severe outcomes for most people, but we're still in it, and we're still trying to make those right choices, and feeling a lot of decision-making fatigue. So think of Thanksgiving weekend coming up, and a 7-year-old grandson comes home from school tomorrow with a cough. So do you call off Thanksgiving or not? Well, what if the 85-year-old grandfather has COPD and might be vulnerable to respiratory? And so we are all just exhausted as we try to sort out real anxiety from excessive anxiety, from moral anxiety. And as you can imagine, I've spent a lot of time with patients over the last 2.5 years, on the telephone a lot, helping people who are anxious, trying to sort through what's real, what's excessive, what are right choices, and accepting that there is no perfect right choice, and there's a uncertainty no matter what we choose. So back to fear of falling and applying all of that to fear of falling. So falls are a real anxiety. Falls are a major cause of hospitalization in the elderly. It's actually a significant cause of death. You fall, break your hip, it gets infected, you might die. Fear of falls often starts after a fall, at least about half the time. And older adults may sense that they have poorer balance and walk with their legs slightly further apart to correct for that. And so we need to feel real anxiety. And so fear of falls can be protective in avoiding high-risk activities. On the other hand, fear of falls can also be phobic. It can be excessive and it can be avoidant. So fear of falls can occur without a fall history, without a problem. And fear of falls becomes unprotective if it's excessive. It can create a vicious cycle of fear of falls causes less activity. The person avoids going out for a walk, avoiding certain social activities, avoiding contact with other people. That in turn leads to isolation, leads to further physical and mental decline, and then actually comes around and leads to more falls. So one is always working in between as one working with fear of falls. It's a real anxiety, and often is a very important real anxiety. It can also function even at the same time as a phobia. So how do you treat it? Well, it's a real anxiety. It's a real issue for the elderly. So you might want to treat it with exercise, balanced exercise. And this is often done with some moderate success. And to quote from another article on anxiety disorders in older adults, and this is an interesting little quote, these authors, medical authors, like Tai Chi. Tai Chi is good stuff. Tai Chi is effective in reducing falls and fear of falling in older adults. This is a quote. Its greatest benefit is enhancement of balance confidence. Individuals are challenged to move through positions with a reduced base of support. Challenge you to stand on one leg. Tai Chi also promotes relaxation, awareness, and focus as a form of physical therapy. And we could say the same about probably yoga and a whole bunch of other things that older adults do intend to find useful. I would just add to that, though, that effective therapy for fear of falling should do three things. It should improve balance, it should increase confidence, and it's also important that it decreases avoidance of activities. You'll recall back in that first slide that anxiety disorders are characterized by avoidance. So we're often wanting to challenge that avoidance, and so sometimes in fear of falling, combining exercise with some form of cognitive behavior therapy, but also making sure that the person is not avoiding, that they're doing the things they need to do to live well. As you can imagine, I work with older adults. A lot of people come into my office using walkers, and a walker is often a topic of discussion, including that many older adults resist using walkers. They don't want to be seen as old and frail. We unfortunately kind of stigmatize that in our culture. And so they might prefer to avoid activities rather than use a walker. You know, I don't want to be seen in church with a walker, so I won't go to church. So again, a CBT, a cognitive therapy, but finding the right attitudes of cognition. And so what is the right attitude that allows a walking aid not just to help you with your balance, but also restore confidence and get you active again? Well, the right attitude looks like one of these three different quotes from three different patients. From the first patient: I used to refuse to use my walker out of vanity. I now realize that it is my freedom machine. I walk straighter with less pain and feel safer. Or another patient: I discovered that I could go to the farmer's market and walk comfortably, even on uneven surfaces. I had a great time. Or another patient, this was actually following a stroke: I walk with a normal gait when I use the walker, which I think is a good thing. So yeah, that freedom machine right attitude allows the walker to restore fear of falling, self-efficacy, self-confidence. I want to go back and make a couple of notes about a couple of other anxiety disorders. One is social anxiety. Like panic, like most anxiety disorders, social phobia actually becomes far, far less prevalent as we age. If we compare those under 55 to those over 55, this is data from the US Surgeon General. It appears to drop from 7% of the population to 1% of the population. Now, 1% is still a lot of people, but that's a huge drop. But it looks, and older adults are gaining social confidence as they grow older. But growing older requires more social confidence. Why? Well, here's one of the challenges of growing older. A lot of your social network is going to disappear. They're going to die. You're going to attend a lot of funerals, unfortunately. And successful aging requires us to continuously rebuild our social lives as we age. And so that requires a social confidence. And if you're not confident, then that could lead to what's been called an intimate loneliness, that you don't really have those same intimate connections that you used to have as your social network, as your loved ones unfortunately die. So the take-home message there is very simple: keep building your social confidence. throughout your life is important. And I'll add in another little note on another anxiety disorder, though in DSM-5 we've separated it out of the category of anxiety disorders, but it is still an anxiety disorder in many ways, post-traumatic stress disorder. And I think one of the Adam lectures a couple of days ago was on PTSD. So very simply again, if we, just the topic of a new PTSD, a new trauma, older people caught up in the Ukrainian war, caught up in the disaster of the flooding in Prince Edward Island or Florida. There's very little difference between younger and older adults in the incidence of PTSD or the types of symptoms that might occur. But what we do find, and it's interesting in looking at PTSD in older adults, is the way in which it sometimes reemerges in later life from early life trauma. And it might reemerge in late life from even childhood, because there might be new triggers that are occurring. It might be, unfortunately, reoccurring because of neurological changes, and unfortunately that word dementia, but also from lifestyle changes as we age, which are the interesting little tidbit I want to give you. So why is it bothering me now? And you don't have to have PTSD to be in my office. Many older adults, especially in their 80s, will have varying forms of asking me, why is it bothering me now? But studying severe PTSD can give us a clue. So the graph there is based on prisoner of war veterans in World War II. Now, World War II was a long time ago, but we've had the advantage of being able to study these people right through their lifetime, for the 60, 70 years they lived after World War II, and to see what happens. And prisoner of war were the group of people in the war that suffered the worst degree of post-traumatic stress disorder. Prisoner of war veterans were much more likely to get PTSD even than those that were in the frontline combat. So what happened with these people as they aged? And so the first bar there is the first year after discharge in 1946, 1945, 46. And yes, 70% of prisoner of war veterans had PTSD. That's incredibly high. But with each following decade, as they came home, married, raised families, went to work, the rate of PTSD went down and down and down to just around 20%, until they got almost exactly to the age of 65. And then it started going back up again. Actually, about 10% of them, so not for everyone, but about 10% of them started to re-experience PTSD in late life, particularly after they retired. So what happens when we retire? We lose the daily structure of that work provides us. We lose some of the social contacts that work provides us. For people in first responder professions like police, firemen, they lose the camaraderie that is around them and supports them at work. And so there is, in police, firemen, and others, there can be also a reemergence of PTSD symptoms after they retire, after they leave the force. And so what, again, what's the take-home message? And it doesn't just apply to PTSD as we age, it applies to all those things that might bother us as we age. Why is it bothering me now? So the take-home message, again, real simple, we already know it. Staying active and connected in retirement helps us manage worries and bad memories. You need to keep creating new memories, or the bad old memories will predominate in your thinking. It's that simple in a way. So stay active. Volunteer. Volunteer with Adam. So a take-home message here about anxiety in old age. And the first one, surprising one, but you now know why I'm saying it. Keep exercising your balance. Prevent fear of falling. Stay active, stay socially active as you age and retire. But also take with you, hopefully from today's lecture, and hopefully you will also take my recommendation and listen to Laura Carstenson's TED Talk on older people are happier, that maybe you will think that, well, if older people are smarter and generally manage emotions well, maybe we can learn from older adults how to manage anxiety. Laura Carstensen ends her TED Talk with the following comment. She says, quote, "My father, who is 92, likes to say, let's stop talking about how to save the old folks and start talking about how to get them to save us all." Can we tap into the wisdom? Can we tap into the wisdom of older adults and help teach children in school and preschoolers how to develop a better ability to confidently manage their emotions as they go through the lifespan to older adulthood? And that allows me to return to where I started, my good friend, Dr. John Walker, who, especially later in his career, emphasized that since anxiety disorders start when we are young, that we need to really have early treatments for anxiety in young children. And he is the prime source of the development of a program called Coaching for Confidence, which has been used in schools, it's been used in hospitals, and is available through Adam. The Coaching for Confidence program, and it says at the bottom, developed by Dr. John Walker. And I'm always heartened when I see his name. So yes, older adults and providing service to older adults is important, especially around issues like caregiving and other things that they have to adjust to. But strangely enough, looking at older adults reminds us that anxiety disorders start when we're young, and to develop services that help impart the wisdom of older adults to young children. So I'm going to stop there. Thank you very much for listening, and I'll turn it back over to our moderator, who will hopefully have some of your questions for me.
Awesome. Thank you so much.
I'm actually going to stop sharing.
Sure. Perfect. Thank you so much for your presentation. That was very informative. We do have a couple questions in the question box. One that came up quite a bit that I can answer is, will these slides be available to participants? And everyone will be receiving the presentation next week if you are registered. So it will be sent out by email. Okay, now I have some for you, Dr. Sexton. Can you address the relationship between testing with mild cognitive impairment and risk developing dementia? How long from first diagnosis?
An excellent question, and I guess it goes to the heart of what I was saying, that in one of my slides, that mental decline is the number one big anxiety of all older adults, and that appear to be what motivates this question. So mild cognitive impairment is a relatively new diagnostic category that is in a zone between normal and dementia. It's not a precise category, though we have some cutoffs and testing that we use. So yes, there is a risk if one is tested and receives the diagnosis of mild cognitive impairment. There's about a 15 to 20% risk each year that might be developed into a dementia, that the mild cognitive impairment is really a sign of early dementia. But it's also important to note that sometimes mild cognitive impairment doesn't get worse, never develops dementia, sort of becomes the new normal for somebody, and then sometimes, especially if the mild cognitive impairment is occurring because of too many medications, side effects of medications, or other things that are happening, it can remit and go away. So yes, there is a risk of it going on to dementia. How long? I hope I'm implying in my answer, yeah, the course is just too variable. Certain amount goes on to dementia, a certain amount stays the same, and some of it goes returns to being normal if certain things that are making things worse are removed. Hope that answers that.
Great, thank you. Can the decrease in depression and anxiety experienced also be because we really are looking forward to the end of life?
That's a fascinating question. The old, my patients, but also those who aren't the old are actually, interestingly, less afraid of death than younger and middle-aged adults. Most older adults have figured out that none of us are getting out of here alive, that death is a normal part of life. And at some point, most of my 90-year-olds will say, I don't want to live forever. And my own intuition, and based on experience, is though that around age 40 or 50, there's actually kind of a peak in fear of death. That people become very aware of mortality at that stage of life, and so looking forward to death wouldn't quite account for why depression and panic is also decreasing as we go from 30 to 40 to 50 to 60. However, coming to terms with our mortality is part of the wisdom of old age. So I do think that there's a piece of truth in that question. Yes.
What is the correlation between CPTSD and GAD and depression in seniors? I personally have found an increase in GAD and depression as I age.
Well, there's a huge correlation between GAD and depression. So going back to that research study that I quoted by Corey McKenzie, the U of M professor. So in that study, I didn't mention it, there was a 57% overlap between depression and GAD. So certainly, we tend to think of it as GAD coming first, leading to depression. I'm not always sure that's 100% true. But if we go with that, then yes, GAD creates a significant risk factor for depression.
Mm-hmm. Are phobias the same as triggers? like the ones experienced by people with PTSD and other traumatized people?
Phobias. Well, I'm not quite sure what you're asking, but I mean, a phobia is in a sense a trigger. I mean, if I'm afraid of snakes, then snakes is the trigger, and even a picture of a snake, or even being told we're going out to Toulon, somebody's going out to Toulon where we know there's a lot of garter snakes. So yes, okay, I think I'm grasping the question. Absolutely, in PTSD, the fascinating thing in PTSD is that in PTSD, the phobia is for our own memories. And so that's why modern CBT treatment for PTSD often involves what's called an exposure treatment called cognitive processing therapy, where we, just like with the phobia for snakes, go out to Toulon and hold a snake gradually, hopefully, so that you don't run too fast. But I'm thinking of a wise older adult I once saw who had late life PTSD emerged from being abused, including sexually abused as a child. And he had tutored himself to start writing the memories down on index cards and put the index cards in a sequence of the order of the events they occurred to him. And this was a wonderful self-invented cognitive processing therapy where he was exposing himself to the memories, turning the memory, rather than, he'd never talked about them even to his children all his life, these events, but when his PTSD emerged, he worked with the memories, turning it into a normal story using index cards. So yes, in PTSD, the phobia, in a sense, is for our own memories, and that's the difficulty of treating it in many ways, because it's in here, not out there in Toulon, I hope that answers that.
We have a couple more here. It says, what about other fears? Global warming, climate change, nuclear war, more pandemics? Yeah,
older adults actually are affected by world events and do worry about that. It even has a kind of what might be called a generativity element. Older people worry about the world for their children. As I leave the world, I want my grandchildren to be safe. So yes, older adults do pay attention to world events.
We have one more question here. Distractions seem to be important throughout life to reduce anxiety. To discuss the difference between distraction and repression, good/bad, on the mental and emotional health of the person, and when to seek help, when repression comes into play, and should repression be addressed?
Yeah, absolutely. Good question. So I like to think of a memory, a bad memory abuse, the story back to the patient I just mentioned who was dealing with late life PTSD for abuse. You want the things in your life to be, I'm just gonna, like a book that you can take off the shelf when you want to, not avoid it, and then put it back on the shelf for later and be able to take it off again, rather than pop out at you and hit you over the head. So repression is when we're trying to never deal with it, never talk about it, never. But sometimes, distraction is different than repression, because in repression, whereas I'm trying to avoid it, no, I need to be able to take the book off the shelf, but also put it back on the shelf. And while I want it back on the shelf for now, I can use activity and distraction to keep it on the shelf. But I need to be able to sometimes take it back off the shelf to visit it again. So yes, there's actually, and it's a wonderful question, a huge difference between distraction and repression.
I really like the way you put that. That was very helpful. Okay, we have one more question and then we are out of time. So we'll answer this one. Is there a correlation between dissociative disorders and dementia?
Associative, I'm not aware of a direct answer. Now, the unfortunately sad answer is that there is a slight increase in dementia that appears to result from chronic severe depression, chronic severe anxiety disorders, and actually particularly PTSD. So there is a risk factor. I can't quite extend that to dissociative disorders, but the answer is probably yes, based on the others. The risk factor is not big enough to create a whole generalized anxiety disorder about worrying about that. It's there, but it's far from predictive.
All right, well, that's all the questions we have today. So thank you so much for being here, Dr. Sexton. And just for everyone else, we do have one more talk tomorrow on children and anxiety. So we'll be talking more about our Coaching for Confidence program that Dr. John Walker developed as well. And thank you for mentioning that today. So that concludes our presentation. Thank you so much.
Thank you.